So for this chapter, we're just going to go back to development, but we're just going to focus on the heart. And and then this leads into the congenital heart defects that some babies are unfortunately born with. And of course, it could be pinpointed to whatever didn't happen while it was supposed to have been happening with this heart development in utero. And then we'll just have to, of course, talk about the pathway of blood flow as the fetus is experiencing as far as inside, and then does everything work out okay as far as the transition? So after birth, fetal circulation should stop. Now, so we just look at just kind of like from some general, this is not embryology, but even the author of this chapter said that you as the therapist still would have to kind of understand like what's going on with development. So that way, when you're looking at what's going on with your patient, you can probably pull it together a little bit better to say that the reason why the baby's not really responding to this therapy is probably because of whatever happened during the development process. So we just started with just some general terminologies. The zygote, of course, after the fertilization happens, the cell is going to continue to divide, so it cleaves as the term that they would use for that. And then each of those little cells are going to be known as blastomeres, and then they'll continue to divide. And then by the time you get to around day 4 after fertilization, this blastocyst becomes officially known as the morula. And until that morula sheds that outer coating, it's not going to implant into the uterine wall. So at some point, so around maybe like day 5, day 6, that should happen. And then this chorionic membrane that they're referring to right here, this is going to be the basis for ensuring that the placenta is formed correctly, so that there is that communication between mom and the developing fetus. Trophoblast is what's really going to do the majority of the work as far as to make that connection between mom and the fetus. Tropho, that prefix means to feed, like to seek out nourishment. And then when we talk about what's going on with the placenta, then this should make sense as far as why they call it the trophoblast. But this is pretty much, again, this is just like a really shortcut, because again, this is not embryology, because there's so many other things going on in this and during these stages. But this is good enough, I think, to kind of give us an idea of the progression. And then we're looking at some of these structures, and we know that things like the heart and the lungs, they're going to really need to start developing first. But really, it's your nervous system. So all the folding that takes place, and all of the other like the development, it's so that the developing, so that the embryo will eventually take on this appearance that where you can have like a head and an actual lower segment, or head and tail, if you want to, I guess, look at it that way. But either way, the germ layers, these 3 germ layers here, are the ectoderm, mesoderm, and endoderm. We know that they're going to give way to all of these different organs and structures. As we said yesterday, when we think about what's going on with lung development, they're really going to derive from the endoderm layer. And that would mean like your heart and some of the other, like your muscles and connective tissues and things of that nature, they're going to derive from the middle layer of that mesoderm. And then of course the other structures that you'd expect to be on the outside, like the skin and things of that nature. They're going to come from your ectoderm. On the amniotic and the yolk sacs, they are, of course, vital, so that way the yolk sac is going to provide nourishment until the connection can be made with the placenta and the endometrium. And of course, we know the amniotic sac is going to need to protect the developing fetus, and this umbilical stalk that they're referring to right here. This is just eventually going to become the umbilical cord, so that's like our lifeline that we're going to have. Now, so chorionic villi. Now, at some point, the trophoblast is going to need to kind of break down some of the tissue in the endometrium. And when it does that, it's going to now allow mom's blood to start to pool into these little different sections here, these little different areas. And these little different areas are going to be known as the intervillous spaces. And as we know, the blood should never mix. And this is the most efficient way to ensure that the baby is going to receive oxygen and other nutrients from the mom's blood. So this is, of course, the mom's side, and this is the baby side. So all of these little red, they call them spiral arteries. These little spiral arteries are going to just kind of like provide blood. Blood is going to leave these little arteries and just kind of fill into these spaces here. And then, of course, the vein, so it's going to drain it back. And then all of this right here, these would be like the little villi, the little finger-like projections that are burrowing down into these intervillous spaces. As the fetus develops and gets older, these become even more like sophisticated. They become even more branched. And it's all about trying to increase surface area for gas exchange. So this is kind of like similar to what you expect your alveoli to do, as far as, you know, the more alveoli you have, the more surface area you're going to have for gas exchange. And so even in utero, it's kind of like the same principle. In the beginning, there's so many, but then as the fetus gets bigger and gets older in utero, then there's going to be even more of these, and they're going to have even more branches, and they're going to get thinner as well, to try to also maximize that surface area for gas exchange. And everything is going to, of course, as we'll talk about fetal circulation and with the shunts and that sort of thing. So with the blood passing into the intervillous spaces through the umbilical arteries, it will then, of course, just pick up the oxygen from the intervillous space, and then it'll all return back to this one central umbilical vein. So branches, but then it just kind of rejoins back into just one structure here. Now, if you read in Egan will tell you that the O2 that's available for gas exchange, it's not going to be that much, unfortunately, but it'll be enough to sustain the fetus. So let's say that if mom had a perfect PaO2 of 100, well, the blood that's pooling inside of these intervillous spaces, it's only going to have a PaO2 of about 50, because there's some shunting taking place here, because the blood is leaving these spiral arteries, and then it's going back through the venous system here. But there's still going to be some mixing, and then also mom is not able to give all of her oxygen to this developing fetus, because she's going to, of course, require oxygen to survive herself. And so for that, if the PaO2 is 50, we're going to say it's about 50 in these intervillous spaces, And then the baby's O2 is about 20, 19, 20. Some authors say around 17, but again, it's all like just, it's all approximation. So if the PaO2 is 50 in the villus space, and then the fetus is, and I'm going to just say mixed venous, because as we'll see with this fetal circulation, there's going to be a lot of shunting and venous admixturing taking place. So I'm just going to call this mixed venous, just to be very specific here. The fetus is mixed venous. Which would be like PVO2, if you want to look at it that way. O2 is only about 20. So this is how gas exchange is going to take place out here in the placenta, because if there's 50 here, so we say 50 here, and then it's going to be hard to draw. And then here is 20. So you already see the gradient. There's a gradient of 30. And O2 will go down as diffusion gradient. So it'll end up leaving the intervillus space, and it'll diffuse into the umbilical, into the umbilical artery. And then eventually it's going to return back to the baby via the umbilical vein. So then we say the baby has got about a PO2 of 30. And then there's mechanisms in place to ensure that that PaO2 of 30 is enough to sustain life. And of course, all the other essential nutrients are going to need to be passed over from the mom to the baby. And because the baby has only got a PaO2 of about 30, he is really going to need a lot of iron, because he's going to need to produce a lot of hemoglobin to increase his O2 carrying capacity. And he's also going to need a lot of amino acids. So mom's got to ensure that she's taking her iron supplements if she's slightly anemic, and also the other prenatal vitamins, and also just eating enough to ensure that the fetus is getting everything that he needs. Now, so then we look closer at the umbilical cord, then all we're doing, so if you're on the delivery team, so the delivery team is usually you and an RN. That's how it usually goes. Sometimes they may have teams of just 2 RTs. If it's like a case that's not super complicated, then it'll be fine with just 2 RTs doing whatever that needs to be done. But either way, whoever's on that team, one of you are going to need to check to make sure that all the structures are in the umbilical cord. I mean, we're supposed to see 1 big vein and 2 tiny little arteries. And if you don't see one of them, then that could explain some of the things that you may see with the baby, as far as the baby's not really progressing or is really having a hard time with maintaining oxygenation, or maybe explains why the baby was born so small, because one of those vessels was maybe compromised or missing. So things happen again in utero during development where every structure doesn't complete or doesn't show up when it's supposed to show up. So you're looking, and you're also just checking the overall quality of the cord itself. So inside, to protect those vessels and to try to minimize the kinking that can sometimes happen, especially the fetus is starting to move around a lot in utero. I mean, they're essentially doing backflips and somersaults. And so that means that that cord is very likely sometimes to get twisted up, knotted up, kinked. So this Wharton's jelly is there to kind of help to keep that from happening, but it's not going to completely prevent the cord from getting knotted up. And you'll see that in delivery sometimes the cord has been completely like tied in a knot. And we know that that's not good because that means that blood flow is being compromised. And then again, here's a better picture, I guess, because they made it a little bit more clear. Like those, these are the mom's like arteries. They call them like spiral arteries that are providing the blood to the intervilus space, and then the baby's actual chorionic villi that are projecting into that space, so that way the blood does not touch at all. It's just a matter of just simple diffusion and active diffusion that's going to take place to get things from one to the other. Okay. Now the heart. Now the heart, it really is going to be necessary to finish development pretty early on. So it needs to be pretty much completed by the second month. And as far as the structures, it's going to start off looking nothing like the heart that we know, as far as the four chambers and the valves and the septa and all those other structures. So it just kind of starts off looking like two tubes, essentially. And these two tubes are going to kind of like come together. They're going to merge together. And then there's going to be some rearranging, some twisting that's going on. And then eventually those other structures are going to be a little bit more defined later on. And I'm not really going to get into all of these terms here on the side. So don't worry about remembering whether this is the bulbus cordis or if this is the sinus venosus. One thing I wanted to point out is our heart, it starts off where the atria are on the bottom and the ventricles are on the top. And then we know that eventually the heart ends up repositioning as it's growing in development and developing, where your ventricles are going to be on the bottom and the atria on the top. So our heart is upside down, which is why we always say that the very tip of the ventricles is considered the apex of the heart. But again, gravity, there's no way that our blood will circulate appropriately if the heart remained in that original position where the atria on the bottom and the ventricles on the top. Now this right here, by day 24-ish, this is the beginnings. Like the truncus arteriosus. This is where we're gonna eventually see those distinguishing, like your pulmonary veins, your pulmonary arteries, and so forth. So when we look at like our cardiac anomalies and our congenital birth defects, truncus arteriosus is something that can be a problem if, again, development didn't completely take place like it was supposed to, and things didn't transition like they were supposed to. All right, so as we see here, just to say, by the first 3 weeks, within the first 3 weeks, it's a heart, but again, it's not the heart that we know yet. It still has some more developing to do. Now, early development, the angiogenic clusters. Angiogenesis just means that you're producing new vessels, like new blood vessels. So these little clusters are what's going to ensure that the heart continues to develop like it's supposed to. And then, as I said, the heart is kind of like it's kind of like two tubes. And in the beginning, when blood is flowing through the heart in the very early stages, it's going in two different directions, and there's no valves yet to kind of keep it going in one direction. So again, it just takes a little bit more time to get it to where it needs to be. All right, so blood flow and heartbeat determined by day 22. So that means that it all depends. I mean, these days, a lot of times I think expecting moms will just buy like a little ultrasound type of device, a little Doppler kind of thing, and check to see if they can hear the heartbeat. Usually if they go in for their follow-up appointments with their OB, then they could probably get somewhere like around 12 weeks, maybe sometimes a little bit earlier, they can get a good distinct heart sound from the fetus. Now during week 5 and week 6, this is where all of the fine tuning is going to really start taking place, where you're going to get your valves, your tricuspid, bicuspid, et cetera, and separation between them and so forth. And then at the very end, it says that heart rate starts off kind of slow, but then eventually it starts to speed up. And then finally, at the end stages here, this really now looks pretty similar to our heart, with the exception of the foramen secundum, which we know is going to be the foramen ovale. That's a necessary shunt to ensure that the blood just shoots over from the right atrium into the left atrium. I mean, even we still have that foramen secundum in a sense. There's like an indentation that you could see where this opening used to be. It's just a one-way valve, essentially a one-way flap. All right, and of course the fetal circulation itself. So what we expect to happen is, because the baby is not, or the fetus is not exposed to the air on the outside, the lungs essentially are not going to be able to do anything. So that just means that the fetus is going to depend on the oxygenated blood that it just received from the placenta. And the goal is to try to take that oxygenated blood and get it to all of the body, or get it to all the tissues in the body with as little mixing as possible. There's going to be some mixing just because of the way that this system is set up. But if you keep kind of like shunting the blood from one place to the other place, then that's still going to be better than nothing. So if you look at the color coding here, conventionally we know that red, when it comes to the circulatory system, would mean oxygenated, and blue would mean deoxygenated. And then purple would be like a mixture of the two. So we start off strong. We start off with, there's our PaO2 about 30. And then you have to jump into the system. You got to jump into the baby's circulatory system. So once you do that, this is the first place you're going to start to get some mixing taking place. And that will be at the ductus venosa. So we're going to kind of like bypass the liver. But you're kind of mixing with the blood. This is all blue because this is deoxygenated blood that's coming from the fetus's lower extremities. And then those two are going to get mixed together. So then we have it. So we're down to about 70%. And then when you get to the right side of the heart, there's blood that's coming from the head, from the upper region. And it's deoxygenated blood because O2 was just delivered there. It's going to mix with that blood. And then you're going to need to take what you have and shunt it over to the left side. And then, so we're saying, now it's saying like about, these numbers are just approximations as far as how much of the blood is being shunted. So it's not necessarily giving us like a degree of shunt, like how much of a shunt is going on. And as far as how much desaturation is going on, it's just more so just say this is approximately how much of the blood is going to make it over or shunt over. But the color coding is pretty much telling the story. So really, by the time you do reach the aorta, you're going to now start to see a lot of, you're going to have like 60% of the blood here, or go back to the color coding. Now this looks to be like a purplish, meaning that, true, it's not completely desaturated blood, but it's not fully saturated either. But it's enough. It's usually enough to ensure that the fetus gets what he needs. And what's going to happen is, because of the fetal hemoglobin, if you remember, the fetal hemoglobin is going to affect the oxyhemoglobin dissociation curve, and it makes it shift to the left. So the leftward shift to the oxyhemoglobin dissociation curve is going to mean that the hemoglobin is going to hold on to the O2 a little bit more tighter. That, in addition to all those red blood cells in general, is going to kind of help to ensure that the fetus is okay in utero, with just, again, with starting off with only about a PaO2 of 30. And then by the time you do reach the aorta, you're nowhere near that anymore. You've been mixing and mixing and mixing with these other bloods that have been returning back to the heart. Now, just to start back from the beginning again, and we trace our path here. So as the O2 or the oxygenated blood is leaving, here's now the belly button, and now the blood is going to have to find its way into the inferior vena cava. And of course, the ductus venosus is going to allow it to bypass, but notice that some of that blood is still going to go to the liver. And as it does it, it's kind of like here's where we split up. Some of us, we're going to go past the liver and jump into the inferior vena cava, and the rest of us, we're going to go this way, and we're going to end up going into the liver. And which is necessary because the liver is highly active. I mean, it's going to require oxygen. And then you've got blood that's returning from like your gut area and et cetera. And it's going to all end up going through the portal vein. And then all this stuff is going to end up mixing essentially. So that blood that took this detour and went into the liver, eventually it will make its way and back into the inferior, or make its way into the inferior vena cava. So then we're here in the right side of the heart, and again, most of it is going to just, well, about half of it is going to go straight through the foraminal valley, and then the other is still going to go into the right ventricle. So it's going to pass through the tricuspid valve, and then it's going to make its way out the pulmonic valve into the pulmonary arteries. Now, because of the fetal lung fluid, I mean, there's nothing but fluid really in the lungs, and there's very little oxygen. So the combination of those two variables would mean that the pulmonary vascular resistance is going to be really high. There's going to be a lot of vasoconstriction going on. With that kind of vasoconstriction, it's going to be really hard for that blood to make its way out to the lungs. A little bit does still, maybe about, they said about 25% maybe will still make its way out there, but we know it's not going to be worthwhile because the alveoli aren't going to be able to do anything right now. So because there's so much resistance to blood flow in those pulmonary arteries, by the time the blood does make its way into the pulmonary artery, the path of least resistance, where is it easier to go? Is it easier to go out to the lungs where there's a huge amount of resistance to flow? Or would it be easy just to shoot across this opening here, which is our ductus arteriosus? And of course, it's going to be much easier for the blood just to shoot across into the aorta via the ductus arteriosus. And then to follow the blood that went over from the right atrium to left atrium, now it will go through, of course, the bicuspid valve and then out the aortic valve. And then now it makes its way into the ascending aorta. And we know the branches of the ascending aorta, we've got the coronary arteries, because heart needs its blood supply. And then we've got our upper segments. We're going to have our carotid arteries. This is our right carotid. That's our left carotid. And then this would be the brachiocephalic. So that means that the right side of the arm, the shoulder, the arm, right arm, is going to receive oxygenated blood as well as the left side. Now, we'll talk later about when we get into the actual heart defects, we'll talk about the whole point of monitoring saturation, whether we're looking at comparing the saturation between the right side and the left side of the body. And it's really not right side or left side of the body. It's before the ductus arteriosus and after the ductus arteriosus. Or are we looking at comparing like the PaO2 from those two regions? So then once we've gotten past all of that resistance and we made our way into the aorta, or now in the descending aorta, then we're just going to travel, and the lower extremity still requires this oxygenated blood, or what's left of the oxygenated blood, still going to require. And then this is now also going to give the blood a chance to, some of it to return back to the placenta. And we've got two arteries where that's going to happen. And then once back to the placenta, it just all starts over again. So as we see, we know that it's important. The placenta is not only going to ensure that there's gas exchange or there's O2 available, but also to help the baby's liver out, because the liver, although active, is not completely mature. And even as the fetus grows, he's still going to need some help with clearing out all those toxins and things of that nature. Like, there's still a lot of chemical reactions going on in the body, in the developing baby's body, which means that there's going to be some substances that need to be broken down and cleared away. And also, again, those other vital things that the fetus is going to need, it's going to come from the placenta. Now, the placenta, being that it's such a low pressure kind of system, that's what's going to ensure that enough blood will make it there, so that as the fetus's blood is traveling, then there should be proper gas exchange taking place. And that's one of the main reasons why also that a mom who's expecting could almost expect that her blood pressure is going to drop. So sometimes it's not that much of a drop, but in other times it might be pretty significant. So we're looking at like a systolic drop of like maybe 10 lower than normal, and a diastolic like maybe 15 or 20 below normal. And again, that's just to kind of like relax everything and make sure that ample amount of blood can make its way to the placenta. Now, anything else? Oh, because there's so much going on at the placenta, it's really the fetus's lifeline. So it's not unreasonable to say that pretty much half of the fetus's blood volume is going to be in that placenta, trying to undergo gas exchange and receive all those nutrients and things of that nature. All right, so we just talk about the three shunts here. The ductus venosus is, of course, the first place, which would be right there to the liver. So this is how the blood gets onto the freeway from coming from the placenta, and then the foramen valley, and then the ductus arteriosus. Now, what is the whole point of having these shunts? As we know, the lungs don't work. They can't work. They're filled with fluid, and they're still, I mean, the baby still is breathing. I mean, the fetus is still like doing this, like they call it practice breathing, still like, using the diaphragm, and the lungs are kind of like expanding and and recoiling, but there's no real breathing in the sense of breathing going on. All right, so then the very last thing here, for sure, the placenta will be the fetus's lungs, kidneys, and liver. Really, it's going to serve all those vital functions and help with those functions. All right, so we're just still tracing blood flow, and we start off at the placenta, and the blood has just received O2. It's just the gas diffusion has just taken place. And then we start off at the ductus venosus, and then there are those numbers. Again, they were including them in the figure as far as percentages, but we're going to say about half of that blood is going to end up jumping into the inferior vena cava, but then the rest of it will end up going to the liver. And unfortunately, when it does find its way into the inferior vena cava via the ductus venosus, then there's going to be the first place where there's an admixture that takes place. You're going to have the deoxygenated blood that's just returning back to the right side of the heart like it normally would. And then again, the part that the blood that decided to go into the liver instead, it's going to eventually make its way back, or it's going to eventually make its way into the inferior vena cava. And then the foramen valley, as we know, and that's the place where you're going to ensure that the blood will end up going to the left side of the system, which is where it's going to do the most good. Because if it all tried to go into the right atrium, from the right atrium to the right ventricle, and then into the pulmonary artery, then that's again not really going to benefit the fetus at all. So we got to have that foramen valley to try to get the blood quickly over to the left side of the system. So it's kind of like pretending that the blood did go to the lungs and it did receive oxygen, and now it's heading back to the left side of the system. So we're just going to bypass all of that, really. Now, the blood is coming from the superior vena cava, is mixing with the blood that just got there from the inferior vena cava. So I've seen this argument go many different ways. I've seen some people argue that there's some other kind of mechanism in place where the SVC is not really mixing that much with the blood that's in the right atrium. And they got all technical with it in their explanation. And then there were others who said it's still significant. Even if it's just a little bit of mixing that's taking place, it's still significant because it's taken away from the oxygenated blood. And then that last shunt there, we know the ductus arteriosus, and we still have this. It's just a ligament. It closes as we know, but it doesn't just completely go away unless you have it surgically removed. And the same would go for like our umbilical arteries. We still have those umbilical arteries, but they don't look like they used to look when we were in utero. They're just ligaments now, and they're connected to somewhere in somewhere behind the I'm rubbing my area and I can't think of the real name for it, but it's still there. It's just like ligaments for the most part. Okay, and again, because of the the increase in vascular resistance, the pulmonary vascular resistance, any blood that tries to make its way out into the lungs is really going to have a hard time. So about 25% of it will, but then the rest of it, as we know, will end up just taking the path of least resistance and shunting over through the ductus arteriosus into the aorta. So these are the different factors here that are going to be responsible for this really high PVR. It's, there's not much oxygen for one to begin with. Anytime there's hypoxia, there's going to be vasoconstriction. As far as there's going to be pulmonary vasoconstriction, which is why we always would need to think about providing O2 to someone who does have increased pulmonary vascular resistance that's causing pulmonary hypertension. And then we know that eventually that blood will have to make its way back to the placenta, and that's again the reason why we have these two umbilical arteries to take care of that. So here's a quick video just to recap fetal circulation. And of course, we know the whole goal is to ensure that the fetus's developing body gets what it needs. And I thought I had it ready to go. I think it's here it is. Oh, and also, just in case there's some network stuff going on again today, let me just go ahead and post or paste this link in the chat as well, because we never know with this Teams what's going to happen from day to day. All right. Wait a minute. Okay, where you go?
Let's go back to 18 days after conception. Looking in the mother's uterus, you can see the embryo surrounded by its yolk sac and amnion. Let's take a look inside. Here's a diagram of the embryo seen from a side view. Right now, it's about the size of a raisin. There's the head region, and that red-colored area slightly above it contains two tubes that will form the embryo's heart. Here's what the tubes look like from a front view. On day 21, we see that the primitive heart tubes have moved below the embryo's developing head region. And by day 22, the tubes have fused together and have moved to the area that will eventually be our embryo's thoracic or chest cavity. It's also about this time that the heart begins to beat for the first time. Here's what it looks like from the front. Now, let's go back to day 18 and watch this happen from a different viewpoint. Here are two tubes in our embryo's chest region seen from a front view. Watch this. Over the next 2 days, these tubes fuse together. Here's another amazing part. The tube now starts bending and twisting, and over the next 8 days, it forms a simple version of the heart. By the time the embryo becomes a fetus at 2 months, the heart bears a close resemblance to what it will look like after the baby's born. But the resemblance is only superficial. On the inside of the heart, things are much different in both form and function. Here's a newborn heart on the left. Let's take a closer look. There's the right atrium, right ventricle, left atrium, and left ventricle. The two major blood vessels are the aorta and the pulmonary artery. The pathway of blood in the newborn heart works like this. Oxygen-poor blood from the body enters the right atrium, then goes to the right ventricle. From the right ventricle, the blood is pumped to the lungs, where it becomes oxygen-rich. Then, the blood flows back to the heart, filling the left atrium, and from there, onto the left ventricle. The left ventricle pumps the oxygen-rich blood through the aorta, which carries it to the rest of the newborn's body. You can see the fetal heart has the same basic components as the newborn heart, but there are a couple important differences. Because the placenta is providing all of the oxygen the fetus requires, its lungs are not needed to perform this task, and therefore, much of the fetus's blood is detoured away from the lungs through two openings or connections. They are the foramen ovale, which connects the right and left atria, and the ductus arteriosus, which connects the aorta and the pulmonary artery. As blood enters the heart into the right atrium, some of the blood flows into the right ventricle, as in the newborn. But also notice that some blood flows directly into the left atrium through the foramen ovale. This blood will pass directly into the left ventricle and be pumped out to the body without ever having gone to the lungs. In addition, some of the blood that did enter the right ventricle and would normally go to the lungs never reaches the lungs. Here, let's watch. As blood is being pumped out of the right ventricle towards the lungs through the pulmonary artery, some of that blood escapes into the aorta through the ductus arteriosus, bypassing the lungs as it does. These two important connections will remain open up until the time of birth. Within 30 minutes after the baby's first breath, the ductus arteriosus will completely close, and the flap of the foramen ovale will shut off like a valve. This happens because of an increase in pressure on the left side of the heart and a decrease on the right side. These changes in the heart anatomy cause the blood to flow to the lungs, which will take over their lifelong job of supplying oxygen to the body. It's incredible to think that this complex organ started off as a couple of tubes only 2.5 weeks ago.
Okay, so what this video is, the sound quality is not that great, but I felt that it did a pretty good job just recapping what was in the beginning of this chapter, as far as, you know, how the heart starts off and eventually becomes the heart that we know. All right, now, okay. So this exercise, I wanted to see if you could do, and these are the different structures here. So we've got which one of these is the abdominal aorta, which is the common iliac artery, et cetera, et cetera, et cetera. And these are in question. So what is this? What is this? That, this here. And so that should be, we've got 10, 14, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Which one? I'm missing this one. Here we are. And this. Okay, so let's take a 10-minute break, and then we'll go ahead and finish off this chapter.